Welcome to the Hazard Class Podcast. This is the podcast where I get to ask my stupid questions to some of the smartest people in and around the world of emergency services. My guest this week has a resume so vast that I struggle to put it into this short format. I'm going to try my best, and I'm probably going to sound stupid just reading his resume. That's how far above me he is. But my guest has worked as an emergency room physician, a medical toxicologist, an occupational and environmental medicine physician. He's currently a professor and the director of the Center for Firefighter Health Collaborative Research at the University of Arizona, Mel and Enid Zuckerman College of Public Health. His research projects have been focused on reducing toxic exposures, preventing injuries and illness among firefighters and other first responders. He is leading a research team that's established and is now expanding the Firefighter Cancer Cohort study, which is a national multi-center prospective study including exposure measurement, biomarkers of effect, and cancer outcomes. This week, it's truly my pleasure to chat with Dr. Jeff Burgess. Welcome, Dr. Burgess. Thanks for joining me.
Thank you, Jake.
Of course, yeah. So as is the format of the show, we'll open up the show with hopefully my dumbest question of the today. So I'm going to spin the wheel of stupid questions, and then hopefully I don't answer any or ask you anything stupider than that one. Here we go.
Spin that wheel of stupid questions.
All right, time to spin the wheel. So we'll see what we get. Okay, this is a really dumb one. It seems like every week they get dumber and dumber, and my guests get smarter and smarter. So when you're getting dressed, do you go sock, sock, shoe, shoe, or sock, shoe, sock, shoe?
I guess I put the socks on first and then the shoes.
Yeah.
The socks together, yeah.
I didn't even realize this was a controversy until I started having this conversation with a few people. Apparently, there's some people out there that go, put a sock on, then put a shoe on, then put a sock on and another shoe. That seems absolutely insane to me. But apparently, there's a population out there that does that. I'm sure it'll be controversial in the comments or something, but I don't know.
And here in Arizona, sometimes we don't put socks or shoes on. So
yeah,
unfortunately, sandals.
Yeah, unfortunately, we don't have that benefit in Minnesota for a lot of the year. All right, so I'll stop wasting your time with the stupid questions. Let's get to the man behind the science. So I see in your resume, you kind of went through med school and you started out as an emergency room physician. Did you grow up wanting to be a medical doctor?
No, actually, I didn't. I wanted to go into the foreign service, but I failed the exam and I had to figure something else to do.
Wow. And so you chose medical doctor. What a big swing.
Well, you know, I like the idea of helping people and also, you know, the problem solving part. So
then you went from, working in the ER to then working as a medical toxicologist. How did you kind of make the switch from, patient care to research and the things you're doing now?
Well, I really enjoyed the patient care, and I enjoyed the research as well. So, but at a certain point, if you really want to focus on your research, it's hard to do both. And so that was kind of why I did the transition from predominantly clinical to currently all research.
So why toxicology? Well, why is that the thing that sparked your fancy?
Well, I actually found it really interesting when I was an emergency physician treating people, the ones that would come in with occupational exposures. And actually, a lot of those living in Arizona, where it can be like mining related things, it was just really interesting to me that people were getting exposed at work. And the idea of like, hey, we should be able to do something about this, right? So that's what got me started. And so the clinical toxicology is taking care of people that were either poisoned or exposed to chemicals at work. And then the toxicology classes I took at the same time were about how you measure those exposures and how you reduce them.
So then you started out with dealing with the miners in Arizona. Is that kind of where you started out with toxicology? Is that right?
I would say that was some of the first cases that we had that, really sparked my interest. But, unfortunately, people get exposed to things all the time. And, people can get really badly affected by acute exposures as well. So there were a number of things, but yeah, the mining certainly stands out in my mind in terms of some of the really heavy duty exposures that people can get.
So then how did you make the switch to first responders or the firefighting community? Was that like you have firefighters in your family, or was it just kind of a natural progression from toxicology standpoint, or?
Well, I would say more that when you're an emergency doc, you work with firefighters all the time, particularly, fire service paramedics. So, you get to become familiar with them. And then when I was doing my classes that were associated with my medical toxicology training, we focused on respiratory protection. So my advisor was the one who developed a way of testing fit tests on respirators. So we worked with firefighters to look to see how well those things fit. And then I started thinking about the things that firefighters got exposed to. And then it just kind of went from there. And then I moved from Tucson to Seattle, University of Washington, where I did an OCMed fellowship. And there I was put in charge of evaluating the firefighters' annual medical physicals. And we found a number of things that were concerning that we had to address and figure out why they were the way they were. So, and then I came back down here and then it just went from there. We just get more and more involved with firefighters. And I will say that working with firefighters is great because they care, right? And plus they're fun to be around. They're generally, pretty happy people, but they care about each other too. And I like that a lot.
So tell me this. I have a question kind of in plain terms, because so often when we hear about cancer in the fire service, there's big terms being thrown around stuff. Tell me this, and maybe it's not an answerable question, but I hope it is. Me as a career firefighter, what is the likelihood that I'm going to get job-related cancer? Is that an answerable question?
Yes. I mean, you have a higher risk of cancer than the general population. Obviously, people in the general population get cancer as well. And so the studies that have looked at it in the past would find that, you'd have anywhere between like a 10 to 15% higher risk of overall cancer of any type than the general population. Those were exposures that occurred earlier, like back in the 70s particularly. So we don't know exactly how much those risks have changed over time in terms of, are they higher? Are they the same? We don't know. But certainly in terms of developing a disease related to your workplace exposures, you have a higher risk of cancer and cardiovascular disease than almost anything else.
So this brings me to my next question. Is like, how does, just being a firefighter compare to other things that people typically associate with a higher risk of getting cancer, like, say, smoking or something else? How does that relate? How do they compare?
Yeah. Well, smoking is really bad. And you smoke all the time, right? Well, not everyone smokes all the time, but many smokers smoke pretty continuously while they're awake. And so you're getting a lot more exposure there than you are intermittently as a firefighter. So, I mean, I haven't actually been asked that question before, and it's a great one. But I would say, not looking into it more, but just giving you my opinion, that smoking would be worse than being a firefighter.
Well, that's good news, I guess, for me. So there's a little bit of misunderstanding about cancer, I think, and definitely from my perspective. Why is it that some people will develop job-related cancers after just a short time in the fire service, and some people can work an entire career worth of exposures and never have any issues?
That's, again, another really important and good question. And what I have seen is that people just vary based on their susceptibility to exposures. They may just, humans are so different. And so we've seen in the past, for example, an exposure, this isn't firefighters, but I'm going to give you just an example of a family that got exposed to mercury in their home. The father was trying to extract gold on a stovetop and boiled the mercury into the room. Very high concentrations of metallic mercury. And, one of the family members died who didn't even have the highest exposure, and the other two survived. And so that's just one example of same exact exposure, very different outcomes, just the way that kind of people are.
So is that a matter of personal health or, DNA predisposition, or is it kind of a conglomerative of all those things?
Conglomerative of all the things. I mean, certainly predisposition, if you have, certain DNA sequences, certain what they call single nucleotide polymorphisms, et cetera, we know that those will affect health outcomes, but also, are you exercising? Are you eating well? Are you doing things to protect yourself at the same time? And all of those are important.
What is it about cancer that makes it so particularly hard to treat and so seemingly impossible to cure?
Well, oncologists that treat cancer, I think, will tell you that each cancer is like a different disease. It's the same, some of the basic components of cells getting out of control, right, growing into cancers. But each cancer is different, and some have, are really easily treated and have very low fatality rates, and others, like mesothelioma, for example, from asbestos, which is increased in firefighters, are really hard to treat and almost uniformly fatal. So it really depends upon the cancer, and also it depends on, for many of the cancers, when you find it. If you find it early on, when it hasn't spread, you can just you can cut it out, if you will, right? Or treat it in some other fashion. Whereas if it's bigger and it's metastasized, then your survival rate is going to be much lower.
When you think about, toxicity and carcinogenic exposures in regards to the fire service, what is killing us? Is it the way we operate on scene? Is it the way that we're kind of chronically exposed in the stations? Or is there one thing that's more to blame or the other? Or is it kind of a conglomerate of everything?
Well, I mean, there are multiple components to it, but the things we know is that at the fire ground in smoke, you're exposed to a number of known human carcinogens. So that certainly contributes to it. And some of the studies we've done where we've looked at kind of intermediate markers between exposure and onset of cancer, we can look at things, for example, of how DNA is methylated. And that's known, certain patterns are known to be associated with future risk of cancer. And we see that those change over the first couple of years of being a firefighter. And we can see that of those changes, maybe, if for one big example, about a quarter of them are associated with the number of fires that you've been to in that time period or the number of fire hours you spent. So we have a clear picture there that it's the fire ground exposures, the exposures to soot and smoke, that are driving that increase. Whereas in other cases, it may be shift work. It may be other things. I mean, shift work is a probable human carcinogen. You're also exposed to some other chemicals. You certainly heard of PFAS or the forever chemicals. That's another exposure that we know that is higher in firefighters and also associated with cancer as well. So there's multiple different components that can put you at higher risk.
You touched on it there, which I think is worth talking about more specifically, which is like just you bring up the shift work, but the firefighter lifestyle of high stress, less sleep, strange eating cycles or whatever that might be. How much is that contributing versus the actual like toxicity of, the exposures?
It's all important. And firefighters aren't just at increased risk of cancer from the exposures. We're also seeing, unfortunately, reproductive outcomes, adverse reproductive health effects from exposure as well. So, you each kind of condition, disease or reproductive health probably has specific exposures that are driving it more. But again, it's everything together. That's why, if you can eat healthy, like something like a Mediterranean diet, for example, if you can keep exercising, if you can keep your alcohol consumption, within a reasonable level rather than binge drinking, all those things will help to reduce your cancer risk. And on top of that, obviously, you want to reduce your exposures on the fire ground as well.
You touch on that. I was at the station yesterday and I was talking to some of my coworkers about, I have this guy that's the guy to ask these questions to. What do we want to know? And something that kept coming up was this idea of like, I wish that we could put a number to some actions. Like in terms of like, if I do this, I have a reduction in this quantity. Is that a thing that's possible, or is that really a thing that's just completely varies too much to even say?
No, it is. And actually, the reason that we're even focusing on cancer in firefighters started because Captain John Galata in Tucson Fire Department came to me after Tom Quisnell, one of the Tucson Fire Department's fire investigators, died of leukemia. And unfortunately, his claim was turned down, which it was a presumptive cancer at the time, so it shouldn't have been turned down, but it was. Unfortunately, these things happen. And so because of that, because of what Tom asked John to do, we started the study looking at exposures, to carcinogens in firefighters and the effects of those exposures and what we could do about it. And what we showed was that everyone on the fire ground, not just the entry teams, not just the firefighters and the captains, but also the engineers and the paramedics, were all exposed to smoke on the fire ground. And you could actually measure increase in chemicals in the urine. You look at polycyclic aromatic hydrocarbons, or PAHs. Those are always present when you have incomplete combustion, like any fire setting. And so we can look at increases in the urine with exposure. And we found comparable increases in the guys that were outside and never went into the fire, like the engineers and the paramedics. So I'm getting to your question, Jake, but so when we found that everybody had increased exposures, then we could look at interventions to put in place to see if we could lower those. And Captain John Galata decided to put engineers on air. In other words, have the engineers wear a self-contained breathing apparatus, at the pump panels when they're doing the other things that they do on vehicles. And we found that having them wear the SCBA at the fire ground, which they were able to do, and still do their work, reduced their exposures by 40%.
Wow.
So we were able to put a number there. That was a substantial reduction. From just one thing, and they already have their SCBA, right? They're just nothing, not doing anything different except using the equipment they have. And then for the entry teams, for the firefighters and the captains, they did a wash down after they came out of the fire. So these are the entry teams. They came out before they took off, their SCBA. So while they were still on air, they used, and you've probably seen this before, just a bucket of water, right? A brush, some Dawn soap, and they had one person, kind of clean off the entry teams. And now all their gear is clean. They have less off-gassing, less cross-contamination later on. They did some other additional things like clean cab, et cetera. And we showed that those individuals had a 33% reduction in the urinary pHs from doing those things. So clear numbers. So yes, if you do the research, you can actually demonstrate how effective these things are.
So when you look at the work that you're doing right now, what are your studies focusing on?
We do whatever the firefighters ask us to do. So we have within the firefighter cancer cohort study, we have studies looking at PFAS levels, looking at blood and plasma donation as ways to reduce the PFAS levels. That's something that was funded by the state of Arizona and involved firefighters both in Arizona and outside of Arizona. About 1,500 firefighters are in that. We have a women firefighter study, which has over 900 firefighters. They've asked us to look not just at cancer risk, but also reproductive risk and mental health. So we found there that women firefighters with PTSD have a 2/3 reduction in their ovarian reserve. If you have PTSD, you're likely to get menopause earlier and, or potentially have problems with infertility. So there's another example. With wildland firefighters, they really just want to know what their exposures are and then ways that they can protect themselves. So we're working with firefighters, about 700 wildland firefighters across 4 states, and looking at their exposures and then reporting that information back to them. So those are just some examples of interventions of things that we're doing. In San Francisco, the firefighters wanted to look to see whether a certain nutraceutical could help prevent some of the changes we see that lead up to cancer. So we're doing that with them. And we're going to see whether this nutraceutical helps prevent or reverse some of the changes that we've seen in other firefighters.
The department I work has been making a big push for sauna. Do you have an opinion on post-fire sauna?
Yeah, we did one study on saunas. This is the request of the Scottsdale Fire Department. Both the local and administration wanted us to do this. So they had two training evolutions that they did for most of their firefighters, where they'd go in, with one bottle, maybe 12 minutes or so, come out, do rehab, go back in for another training scenario, in the burn room, live fire exercise. And then after the second fire, they'd again do rehab, and then immediately everyone would take a shower after that. Then half of them went into a sauna, so we randomized them. They went into the sauna, and then half of them did not. And then we looked at the amount of those pHs that I mentioned before in the urine of both groups. And there was a substantial reduction in the urine, the guys that went into the sauna. It was an infrared sauna set at 120 degrees for 20 minutes. They kind of chose the parameters they wanted. No exercise, just that. And it was the infrared sauna. The idea is it makes you sweat, but not raise your core temperature. And we saw that it didn't raise the core temperature, which is good. We don't want it to. We just wanted them to sweat. The heart rate did go up. That's not surprising, but your guys' heart rate goes up all the time, right, when you're working. And there was a substantial reduction. I can't remember the exact number, but it was over 50% reduction, I think, in the urinary pHs in the people that went into the sauna. But it wasn't statistically significant, which means that it may have been due to chance. So sometimes this happens with the studies, even though you see a big change, that it's not statistically significant. It means you have to kind of try it again. And we just haven't gotten to the point of doing that. But we didn't see any harm from it. So my feeling is, at least use the way that we did it. It may be beneficial. Did not show any evidence of harm. So I'm fine with firefighters doing it. I just can't tell them that it's going to work really well. And then the other thing is that this was right at the training center. So immediately afterwards, they got in. In real life, it'd probably be at least an hour, right, from when you leave the scene to when you probably be able to get in the sauna. And so the effectiveness may not be the same in that situation. So as we often say, it requires more research.
Mm-hmm. So one of the other things that we hear all the time in the fire service is the shower within the hour. I'm sure you're familiar. We always question that, not because of the validity of cleaning yourself, but like What if it's not realistic to get clean in an hour, or it takes 3 hours stuff? Is it just a fancy rhyme to say clean yourself after a fire, or does it actually matter to happen within a certain parameter?
Yeah. So shower within an hour is a great rhyme, but honestly, you should shower as soon as you can after a fire. And we've shown, again, working in some of our earliest studies, working with Tucson Fire Department, that if you're one of the entry teams and you're on air the whole time, despite being on air, for every minute you spend in the fire, you have a statistically significant 1% increase in your urinary PAHs. So if you're in the fire for 15 minutes, you'd have a 15% increase in your urinary PAHs. So from my perspective, that is from absorption through your skin, even though you're wearing your SCBA and your turnout gear. And we know that turnout gear is not really good at keeping the chemicals away from your skin, at least kind of the earlier generation. If there's newer generation stuff, I think there's less information on that. But it's on your skin. The earlier you can get it off the skin, the better. And and therefore, I think that was part of that 33% reduction, I think, too, was not just doing the clean of your gear, the wash down on scene, but also getting in and taking a shower quickly. So it is a real thing. It is important, and you should do it as soon as possible. And it's probably not a bad idea to use the skin wipes at this fire scene as well, too, although there's less study on how effective that might be.
So we've kind of touched on some of the things that are narratives in the fire service as far as cancer reduction goes. Are there anything you see in terms of messaging to the fire service that you disagree with or you think are misunderstood?
Well, I have to think about that for a moment. I think that what firefighters do and the messages that go out are pretty good by and large. I think that the idea that you can I think you mentioned it already, Jake, that it's not good enough just to wash your gear off. You need to take care of yourself and wash yourself off too. So, but I don't see that as a message that's put out there. But I think in addition to kind of doing an on-scene wash down, which I think is a good idea, making sure that you take care of yourself, that you clean yourself off as soon as possible, and realize that it's more important to clean yourself off than your apparatus or your tools. So you should take care of yourself first, right, before you do those other things, and then come back out and take care of that afterwards. That's what I would be recommending.
Yeah. So there has also been a push in the fire service to create distance between the turnout gear and the equipment and where we're living in these stations. What do we know about in terms of exposure from just like sedentary gear near us in our living quarters?
Yeah. So the gear will both off gas, and you can have cross contamination from the soot on it. So we know that happens for a while afterwards. And in addition, the most gear has got a PFAS coating, and so that coating could be coming off and potentially increasing your exposure to another chemical you want to avoid, but not just the soot, but also PFAS, and could be other. So if it's in the living quarters with you, you're going to be carrying all that in, and you're going to continue to be exposed to it. Whereas if you have, an area that's segregated for putting your dirty gear, that's going to reduce your exposure, significantly. So I think it is really important to make sure that you've got a place to put your dirty gear. And ideal, as we said, you do the on-scene wash down, and that reduces you. But if you combine that with having a place to put your dirty gear that's apart from your living quarters, that's going to even reduce your exposure further.
But before I let you go here, I want to touch on one thing that you mentioned early on when you were talking about where we're getting some of this cancer data, which is kind of from the 70s, I think you were saying, or maybe the 80s. How are we able to track this through the new initiatives that have launched in the fire service? Even in the last 10 years, it's been a nearly exponential increase in marketing the idea that we need to be clean and do all these things to reduce cancer. When are we going to start to be able to tangibly say we've made this effect on a broad scale of the fire service?
Again, great question, Jake. So I don't think when I was talking about the previous studies, mentioned exposures in the 70s, that's when a lot of the exposures were started, right? But the study was actually done in 2014 or 2015. Okay. So it was more recent, but the cancer is a result of exposures that have occurred over a period of time that's, anywhere between 3 to 30 plus years after exposure. That's called the latency time period. So the exposures that we have now won't show up as a cancer, probably for at least 3 years, and maybe 30 or more years. So after retirement for a lot of guys too. So they can look at cancers in a couple different ways. One way is kind of what they call a cohort study, like our Firefighter cancer cohort study. The other way is to use cancer registries. At each state has one, and you can kind of look there and you can compare people that are firefighters and non-firefighters. And so, those can be done all the time. In terms of the new initiatives, that NIOSH has the National Firefighter Registry for Cancer, or the NFR. That's going to have, when it's fully, when everyone is signed up, hopefully over 200,000 firefighters, it'll be the biggest study ever. And they're going to be able to, with that many firefighters in it, they'll be able to say, well, if your exposure started in these years, your cancer risk is such. And if it started later, your risk is such. So I think from the perspective of cancer, that study will really help to answer it. The other way we can do is, like I told you, we're looking at the effects of cancer. And we know that firefighting, the exposures can lead to cancer by changing things at a cellular level. There's 5 key characteristics of carcinogens that IARC, the International Agency for Research on Cancer, identified as having strong evidence in firefighters. And one of the ones that we've focused a lot on are epigenetic changes. These are changes in gene expression, like turning on and off genes that control cancer, and without changing the underlying DNA sequence. And so we can actually see changes, as I mentioned, within a few years of starting firefighting. So if we're not seeing those changes in the future with improvements in what the firefighters are doing, that's a signal that we'll probably see a reduction in cancer later on. So there's a couple different ways, I guess, to help answer that question. And I think we really need to pursue all of them.
Well, I want to thank you truly from the bottom of my heart, as someone who's had friends and coworkers die of job-related cancer. I really appreciate the work you're doing. Let the people know if you have any resources or anything that you would turn them to find more information. I like I said, I'm very appreciative of the work you're doing.
Well, you can look at our Firefighter Cancer Cohort Study website. It's just ffccs.org. So information on all the studies we're doing are there, the publications that come out of it. And I want to make sure that, before we end our podcast here, that I mention how important the firefighters' role is in this. So we do community engaged research with the fire service. They're involved with all phases of research, from not just asking the questions that then we need to answer, but also helping us to enroll the firefighters, helping us to collect the samples, helping us to understand when the data come out why it is the way it is and what we can do about it. So this is really a collaboration with the fire service. It's not just academics working in their lab at the university. It's this whole continuum. And so it's being involved, having the firefighters being involved in the research is just critical. We could not do it without them.
Well, thank you again for the time today, and thank you for the work that you're doing. I'm super appreciative. I can't express it anymore. I appreciate the time today. Thank you.
All right. Thank you for this opportunity, Jake. I appreciate the chance to answer your questions.